Good afternoon, everyone. My name is Tracy Abel. I'm Director of Operations here at American College of Healthcare Sciences, and it's my pleasure to welcome you to today's webinar on herb-drug interactions. We're excited to be here today with Dr. Forrest Batz to learn more about the important topic of herb-drug interactions. Just a few housekeeping items before we get started. First, I want to make sure that everybody can hear me. So if you can hear me, just take a moment to type a quick hello in the chat box on the left-hand side of your screen. Wonderful. Thanks, Jennifer. Appreciate it. You may have noticed that your line has been muted. We are recording today's webinar, and this just helps ensure a better quality recording. And we will make the recording available to everyone. Great, Audrey, Barbara, wonderful to see all of you, Hillary, Sarah, Darlene. Great. Well, I'm really excited to have you all here. This presentation has been several months in planning, and we're just really excited to have Dr. Batz with us today. We will have a Q&A period at the end of the call. So if you have questions as Dr. Batz goes through his presentation, type your questions into the chat box, and Dr. Batz will answer those, as we go if it's appropriate, or most likely he'll review those at the end. So don't worry, if he doesn't answer right away, he'll see those questions at the end. And if there is something that requires us to do a little more research before we can answer, we'll be sure to follow up with you after the webinar. So now I'm going to turn the webinar over to Dr. Batz. Dr. Batz will give a brief introduction of his background, and then we'll get started with his lecture. So welcome, Dr. Batz. In just a moment, you'll have control, which you are now, and we are now seeing your screen.
Terrific. Thank you, Tracy. As Tracy mentioned, my name is Forrest Batz. I'm a member of the pharmacy faculty at the Daniel K. Inouye College of Pharmacy in Hilo, Hawaii. And for the last close to 20 years, while my background is as a pharmacist, I've been working primarily with natural products, writing and speaking for health professional audiences, and working with consumers to help people understand the information from an evidence base about dietary supplements, herb and non-herb supplements, and help people use them in a way that's most beneficial and effective, especially when it comes to the crossover when people are using supplements and prescription drugs together. I would like to acknowledge at the beginning of the talk that I have been given permission to use proprietary information in this talk from Therapeutic Research Faculty, the publisher of the Natural Medicines Comprehensive Database. I understand from Tracy that you all have access to the Natural Medicines Comprehensive Database through your studies with ACHS, and we'll talk about this a little bit further, but I just wanted to give that disclaimer. I've set up some objectives for you that at the end of this presentation, you'll be able to describe the prevalence and impact of supplement-drug interactions, to discuss the types of evidence used to document supplement-drug interactions, to differentiate between pharmacokinetic and pharmacodynamic interactions, to describe the physiologic function of metabolic enzymes, to define a system to evaluate the significance of supplement-drug interactions, to list examples of significant supplement-drug interactions to avoid, and to identify tools that you can use to identify and prevent supplement-drug interactions. I'd like to begin by defining some terminology. Some of this will play a greater or lesser role throughout the presentation, but I think it's valuable for there to be a common understanding of the terminology I'll be using. When I refer to conventional medicine, I mean Western medicine. Unconventional medicine is everything else, the things that are called alternative or complementary. It's not meant in any way to denigrate any other practices, just to identify them as those that are not in the mainstream of Western medicine as we know it today. And then lastly, I view the term traditional to refer to those things that have been used for hundreds or thousands of years. We often hear people talk about traditional medicine, meaning Western medicine, but Western medicine isn't very old. And those things that we do consider traditional, like traditional Chinese medicine or Ayurveda, do have a history that goes back thousands of years. Today in the talk, I will use a variety of terms interchangeably: dietary supplement, herbal and non-herbal supplement, natural medicine, natural product, and supplement. These all refer to the same category of products, those that are herbal or non-herbal and used for medicinal purposes, but are not classified as drugs or over-the-counter drugs in the US. So also, just to set a baseline, the FDA defines a drug as any substance other than food that's used in the prevention, diagnosis, alleviation, treatment, or cure of a disease. And this is important when it comes to the claims that products make that are classified in the US as dietary supplements. Those products are not allowed to make drug claims, claims of treatment, of prevention, or curing of disease. And we'll touch on this a little bit later, but I just wanted to make this clarification. When I think about natural products, dietary supplements, I think of a drug continuum. And I'd like to present this graphic for you to consider. On the left, we have a raw plant. We might say have St. John's wort. And if we dry that product, we pick it, we dry it, it can be used as a dried raw herb, and it'll contain a mixture of many different chemicals, but all in small quantities. This plant material will have fairly mild drug actions, and it'll also have a low risk of side effects or very mild side effects. If we put that raw herb into hot water and we make a steeped tea or decoction, we will concentrate the water-loving chemicals in the plant, and the fat-loving chemicals will stay in the plant material. So what is consumed in the liquid is then a more concentrated, limited number of those original chemicals. There will potentially be a slightly stronger drug action and a potential for slightly greater side effects. If we go on and in a laboratory make what's called a standardized extract, where we concentrate one particular marker compound without really paying attention to the other things that we're taking out of the plant, and develop, let's say, a tablet or a capsule that is standardized to a percentage of that marker compound, we now have something that tends to be a little bit more consistent in quality, but also it may have stronger effects because we're concentrating a smaller number of those original chemicals. There may be a higher likelihood of side effects and potentially stronger drug or medicinal action. And then lastly, if we take one single chemical from that original plant, we purify and concentrate it, we have the equivalent of a prescription drug or even an over-the-counter drug. These are products that have stronger drug actions, and by virtue of having stronger drug actions, they also have a higher likelihood of side effects. So, my first question to you as a group is, which of the following is a drug claim? A, hawthorn to support healthy heart function. B, Panax ginseng to adapt to stress. C, St. John's wort to treat depression. Or D, echinacea to enhance immune function. And the answer to the question is that C, St. John's wort to treat depression is a drug claim because the product is claiming to perform a drug activity, to treat or cure or prevent an illness. So prescription drugs are highly used. They're the major treatment modality of conventional or allopathic medicine. And for those of you that aren't familiar with it, prescription drug use is greatest per capita among older people. The older people get, the more drugs on average the individual person takes. These are products, these drugs that are therapeutically potent, and their risk of side effects varies both with the type of product and with the dose that's prescribed. When it comes to herb and non-herb dietary supplements, we know that the use is high, but it's relatively leveling off in the US. I believe the number is about 60% these days on average. But again, the greatest use is among older folks. So here we have the population that is using the greatest number of prescription drugs per person on average, also being the greatest users of herb and non-herb dietary supplements per person. Herb and non-herb supplements vary in their therapeutic potency, but they tend to be milder in their effects than prescription drugs, and they also tend to be have lower risk of side effects than prescription drugs. I would like to point out that this discussion is excluding what we term homeopathic products or homeopathic remedies. And the reason is that homeopathic remedies are based on an entirely different conceptual framework. In homeopathy, a homeopathic drug is one that is serially diluted. So in the case of the image here on the slide, we start with an original substance, and we put 1 drop of that substance into a container with 99 drops of a diluent like alcohol. That's termed a 1C dilution, a 1 in 100 dilution. And if we continue to serially dilute by taking 1 drop of the current dilution and putting it in with 99 drops of the same diluent, and continually doing that, we get a more and more dilute substance that is, in homeopathic terms, considered to be more and more potent. So another way to look at it is, the more dilute the product, the more potent it is as a homeopathic drug. I just want to make this clarification that what we're talking about today excludes homeopathic remedies and drugs because they are based on their dilution and not on a pharmacologic potency that we see when we refer to prescription drugs, over-the-counter drugs, and herbal and non-herbal dietary supplements. So now we're getting to the real meat of the discussion today. Supplements and drugs, and what kind of concerns might there be? There is a clear possibility for interactions between substances. We know with prescription drug therapy that individual prescription drugs, when taken together, can cause interactions. Some of them can be beneficial, some of them can be detrimental, and some of them we don't see any real effect even if they occur. The same exists for the combination of herbal and non-herbal supplements and drugs. An example of a desirable effect for a supplement-drug interaction would be niacin and the statin drugs, the drugs that are commonly used to lower cholesterol, like lovastatin and simvastatin. On the other side of the picture, and the things that we're much more concerned about, are the undesirable effects. For instance, the combination of ginkgo biloba and warfarin, which can increase the risk of bleeding and cause a person to have potentially a serious bleed when they're being anticoagulated on the prescription drug warfarin or the brand name Coumadin. There are more than 1,600 potential interactions between drugs and supplements that have currently been cataloged. The evidence for these varies. It can be based on test tube studies, or what are called in vitro studies. It can be based on animal studies, on human case reports, or on human studies. And in Western medicine and in pharmacy practice, we tend to be very conservative, and we want to identify potential interactions. We don't always know if they occur because we don't have the research in humans to tell us, and we don't want to expose people unnecessarily to these potential interactions just to see what might happen. So we do rely to some degree on these animal studies and test tube studies, not that we go out to perform them, but when this information is available, we try to use it, because we would much rather prevent or avoid a potential interaction than overlook a possibility and have it occur and cause harm to someone. I would like to point out that the literature for this, and the biomedical literature, is constantly growing, so the information available is constantly changing, which goes to the last part of the discussion today, which is how to find a reliable information resource that you can use in practice to identify interactions rather than having to keep up constantly with the literature yourselves. So there is limited data on how often supplement drug interactions occur, But what does this mean about the importance and the impact of these interactions? We divide interactions into two types, pharmacokinetic and pharmacodynamic. Pharmacokinetic refers to changes in the movement of a drug through the body, and we break that down into 4 areas: absorption, distribution, metabolism, and elimination. We refer to it in medicine as ADME or ADME, but the pharmacokinetic interactions are the ones that most of you will be most familiar with. Pharmacodynamic interactions, on the other hand, involve changes in the action or effect of a drug in the body, and I'll give examples of both. So as far as metabolism, the metabolic enzymes in the body are necessary to help the body remove or detoxify chemicals that have come into the body. These are mechanisms that have developed over long periods of time that allow the body to change a chemical from one that will reside in the body to one that the body can remove, especially through the urine or potentially through the feces. Metabolic enzyme activity can be altered in 2 ways. It can be increased or induced. The enzyme activity, when it increases, then has its effect to a greater extent on the drug or on the target, which causes the level of drug in the blood to go down, and therefore for the drug to have less of an effect. On the other hand, if a metabolic enzyme's activity is decreased or inhibited, it slows down the activity of that enzyme. So the enzyme is going to be less effective at whatever its impact is on the drug. So the level of the drug in the blood will increase, and the therapeutic effect and side effects of that drug will also increase. The major metabolism in the body involving drugs occurs with the cytochrome P450 or CYP enzyme system. This is a group of enzymes that are found throughout the body in various locations, and the location determines the impact. There are more than 30 isoenzymes or varieties of CYP P450, and only a few of them are really relevant as far as drug-supplement interactions. One specific variety, cytochrome P450 3A4, is involved in the metabolism of approximately 50% of all prescription drugs, which makes it a very important isoenzyme for us to pay attention to. Excuse me. So an example of a CYP 3A4 interaction would be the interaction with St. John's wort and drugs that are metabolized by cytochrome P450 3A4. St. John's wort induces 3A4, which means the activity of 3A4 increases. The metabolism or the breakdown of the target drugs increases. The blood level of the drugs goes down, and the effects of those drugs also are reduced. And this is really the heart of the problem, when the effect of the drug goes down or is reduced because of an interaction. Another type of metabolic interaction involves P-glycoprotein, which is also referred to as multi-drug resistance protein 1 or MDR1. MDR1 is real interesting. It's located in the gut wall, and it actually pumps unwanted substances that have been absorbed through the gut wall back into the gut to be excreted in the feces. So this is a way literally that the body identifies certain substances that it doesn't want that have come in through the GI tract, and then tries to dump them back to get rid of them for the body to remove and have them never enter the bloodstream. So an example of this metabolic activity and interaction involving a supplement, again, involves St. John's wort. And I've used this example on purpose because an herb or a supplement can have more than one interaction effect in the body. In this case, St. John's wort induces MDR1. Remember a moment ago we talked about how St. John's wort induces 3A4, which lowers blood drug levels. But in this case, because the St. John's wort induces MDR1, it causes the pump to work better than normal, pumping more of the unwanted substance back into the gut to be excreted, thus also lowering drug levels in the body and lowering the effect of the drugs in the body. So we have two very different mechanisms, both of them affected by St. John's wort, and the combination increases the overall effect of lowering the level of drug in the body and lowering the effect or the therapeutic benefit of the drug in the body. Now, there are additive and antagonistic effects involved with pharmacodynamic interactions. Up until now, the examples we've talked about were pharmacokinetic. They involved the movement of drug through the body or a change in the movement of the drug. But now we're talking about a change in the effect of the drug in the body. So some examples might include if a person is taking bitter melon with a blood sugar lowering medicine to control their blood sugar, because bitter melon can lower blood sugar and the blood sugar lowering prescription drug also lowers blood sugar, theoretically a patient who's taking both of these could have their blood sugar drop too low and experience hypoglycemia. On the other hand, the combination of bitter orange and caffeine, which is found in a variety of weight loss products and energy products, can potentially increase blood pressure. And if a product containing bitter orange and caffeine is taken together with a drug that is intended to lower blood pressure in a person with high blood pressure, the herbal combination can counter the effect of the blood pressure lowering drug, and the result could be that the person with high blood pressure may not be able to maintain a lower or target blood pressure effectively. Now, when it comes to evaluating the significance of drug interactions, supplement drug interactions rather, we have to look at a variety of concepts and evaluate each of them separately, and then come up with a final picture for that specific combination. And there are a variety of ways in which different publications have done this. I'm going to talk today about the system that was devised by and is used by the Natural Medicine's Comprehensive Database. What you see in front of you is a grid, and along the top are ratings for the likelihood that the interaction will occur. Anything from it's likely to probable to possible to unlikely. Running down the left column is the estimation of the severity of the interaction should it occur, from very high or severe to insignificant or ain't gonna make a difference. Once the information has been charted in this table, we then divide those potential interactions into groups by those that are potentially going to have a major impact on a patient. These are combinations to avoid because if they cause an interaction, the interaction could be very serious to the patient. Those that fall in the yellow category are termed moderate, and we exercise caution. There may or may not be a significant effect, but we want to warn the patient that the potential exists, and we definitely want to monitor the patient more closely if the combination of the supplement and the drug are going to be used together. And then lastly, those combinations that end up being rated in the green boxes are those for which we want to be aware that there is a chance for an interaction, but that even if it does occur, the likelihood is it's going to be minor or not noticeable. We want to advise the patient to keep an eye open for it. We want to monitor a little more closely as clinicians, but we're not overly concerned that those interactions that are rated in the green zone are going to have any serious clinical significance. So we then break down these different categories that have gone into the rating table. In the definition of the severity, we break it down into high, moderate, mild, and insignificant. Everything from if the interaction occurs, it's going to be life-threatening or potentially cause a severe impairment, all the way to insignificant, where drug levels may be affected, but clinically in a real person, we wouldn't see anything that would cause any kind of a change in their condition or the ability of their medications to help with whatever the purpose is the medications are being taken for. We also look more closely at the likelihood of occurrence. And the rating system goes from a high of likely that human research, this is research involving lots of people, indicates that the interaction is likely to occur in most people, all the way down to unlikely that human research indicates it's not likely, or that there is some indication from animal or test tube research, but we don't have any real evidence or any real sense that this is likely to occur in people. We also look at the level of evidence for both the severity and the likelihood of occurrence. And those levels of evidence run A to D. A would be high-quality human trials. You may have heard of randomized placebo-controlled double-blind trials. This is the gold standard for a Western medical human drug trial. And if we get information from a trial like this, we have much more confidence in the information than if it came from anecdotes, from test tube or animal studies, or if we're basing the potential for the interaction simply on what we know about the pharmacology of some of the chemicals that are found in a plant or in a supplement, and extrapolate those to what potentially might happen if taken with a drug where the activities could have an effect either to compound or to antagonize the activity of the drug. So then we come back again to this overall rating where we've looked at the likelihood of occurrence, the severity of occurrence, and the quality or the strength of the data for each of those. And again, we come up with this rating table. The rating table is then applied to an individual product. In this case, the first example is grapefruit juice, and the drugs that can be affected. So constituents in grapefruit juice inhibit cytochrome P450 in the small intestine. This increases drug absorption. The metabolic enzyme is inhibited. It's not working as potently, so it chews up less drug less quickly, which allows more drug to get into the bloodstream, which increases drug effect and drug side effects. Now, what's unique about this is that it takes a very small amount of grapefruit juice to initiate the interaction. Only as little as 120 mLs, about half of a whole grapefruit. The activity starts within 2 to 4 hours, but it can last for up to 72 hours. So this isn't the kind of interaction that people can avoid by separating grapefruit juice from their prescription drugs and taking them several hours apart. That will not alter the effects of grapefruit juice, if adequate grapefruit juice is taken into the body, on the metabolism of drugs that are affected. And again, remember, cytochrome P450 is responsible for the metabolism of about half of all prescription drugs that are on the market. So we caution people about this kind of an interaction because it involves so many different drugs, and it is rated as a red or a major interaction because it has a moderate to high likelihood severity if it occurs, and the likelihood of occurrence is very good. And it's fairly strong evidence from studies that this kind of an activity does occur. Going on to the next example, St. John's wort, we've talked about it a little bit already. St. John's wort induces P-glycoprotein in the small intestine. It reduces the amount of drug that is absorbed. It also induces cytochrome P450-3A4 in the liver, which increases the breakdown of drug. And the overall effect is that it decreases drug levels in the body by anywhere from 15 to 60%, and it decreases drug effects, and this is significant. Some of the drugs that are affected include oral contraceptives, and there are instances of women who, on oral contraceptives to avoid pregnancy, have become pregnant while using the combination of St. John's wort and the oral contraceptive. Some of the drugs that are used to treat HIV infection also are affected by St. John's wort, and people that have been well controlled on HIV drugs have had worsening of their infections when they also took St. John's wort. There are other drug classes and other individual drugs that are also significantly affected, and because there are so many, it's so varied, we caution people to avoid using St. John's wort if they're using a prescription drug, and if they're contemplating using a prescription drug, to have a discussion with their pharmacist or physician if they're using St. John's wort about stopping the St. John's wort before starting the drug to avoid any reduction in the benefits the drug may offer. The next example I'd like to offer you has also to do with St. John's wort, but it's a little different. It involves the prescription drug Plavix, which is known by the brand name clopidogrel. St. John's wort induces cytochrome P450-3A4 in the liver. We just mentioned that. But in fact, clopidogrel or Plavix is not the active form of the drug. It's what's called a prodrug, and it needs to be activated in the liver by cytochrome P450-3A4 to its active form in order to have its drug effects. So whereas St. John's wort reduces the blood levels of most drugs with which it interacts, it actually increases the metabolism of the prodrug clopidogrel, which leads to a higher blood level of the active drug, which means that not only do blood drug levels increase, but so does the drug effects and the potential for side effects. This is well documented. It is potentially a major concern, and therefore the combination of St. John's wort and clopidogrel, or the brand name Plavix, should be avoided. The next example I'd like to talk about is ginkgo and anticonvulsants. Ginkgo can increase the risk of seizures. We theorize that ginkgo may lower what's called seizure threshold, the ability, the threshold at which a brain begins to have seizures. There are anecdotal reports of seizures in patients who have taken ginkgo, and so we want to make sure that they avoid the combination of ginkgo with anti-seizure medicines, which are also called anticonvulsants. And we also want people to avoid ginkgo if they're taking drugs that can lower seizure threshold. We don't want them taking multiple products that can all lower seizure threshold and put people at a higher risk for having a seizure. So again, this is rated as a major drug interaction, and we want people to completely avoid ginkgo, combining the use of ginkgo and anticonvulsants, as well as ginkgo and drugs that can lower seizure threshold. Another example of an important drug interaction to be aware of involves ginkgo biloba and blood thinners. Ginkgo can increase the risk of serious bleeds. There are a number of case reports of serious spontaneous bleeds that have occurred in people taking ginkgo products. Some of the drugs that we're concerned about include antiplatelet drugs. These are drugs that stop platelets from sticking together. Platelets are one of the mechanisms by which, when we start to bleed, the body will try to stop the bleeding. They will, if we start to bleed, the body will activate platelets which stick together and form a thrombus, which is basically going to try to plug the hole where the blood is leaking out. Aspirin and what are called NSAIDs, things like ibuprofen and naproxen, are the kinds of drugs that we're talking about with antiplatelet drugs. We also want people to avoid the combination of ginkgo and anticoagulants or actual blood thinners, like warfarin, which is the generic name for the brand Coumadin. These are drugs that are used to thin people's blood to allow their body to break down clots that have formed internally rather than have those clots stick around, break loose, and lead to a heart attack or a stroke or another serious or potentially deadly event. Because of the serious nature of bleeding, especially involving antiplatelet drugs and anticoagulant drugs, we want people to avoid any combination of a drug that can increase the risk of bleeding on its own together with ginkgo. So, a patient who uses ginkgo and aspirin is at risk for which type of supplement-drug interaction? Is it a pharmacokinetic interaction, one that involves the movement of drug through the body? Is it a pharmacodynamic interaction, one that changes the effect of the drug in the body? Or it's not an example of a supplement-drug interaction at all? And the answer is that the combination of ginkgo and aspirin is an example of a pharmacodynamic interaction. The ginkgo can increase the effect of the drug, which is to, as a side effect at least, increase the risk of bleeding. So it can change the effect of the drug in the body, or magnify it in this case. The next example I'd like to talk about is calcium and drugs that bind with minerals. Calcium, as you know, is a metal, it's a mineral. And calcium physically will bind together with drugs in the small intestine, preventing the drugs from being absorbed and carrying them out in the stool. The overall effect is a reduction in the drug absorption, a lowering of drug levels in the blood, and therefore a reduction in the therapeutic effect of the drug. Some of the drugs that are affected include levothyroxine, which is the replacement for people who have low thyroid activity. Quinolone antibiotics, a category of antibiotics. You might have heard of Cipro or ciprofloxacin, which is one member. The antibiotic tetracycline. And drugs that are called bisphosphonates. These are drugs that help strengthen bones and are used in helping people who have osteoporosis. So, unlike some of the other interactions that we've talked about, this interaction, because it is physical in nature, it involves the physical binding of calcium with the drugs in the small intestine, can be overcome by separating the drugs and their administration times. If we separate the administration or the dosing of calcium by 4 or more hours from the administration of the drug, they will not physically be together in the small intestine, and therefore the calcium can be absorbed or used by the body, and the drug can be absorbed and used by the body independently, but the person can get the benefit of both of them. Now, this is a moderately rated interaction, as you can tell by the yellow coloring, and we want people to be cautious about these combinations. Rather than avoiding taking these drugs altogether, what they need to do is be cautious and avoid taking them within 4 hours of each other. But they can very safely and effectively take both drugs by separating their administration by at least 4 hours. So calcium and other minerals can bind with some drugs in the gut to reduce or prevent drug absorption. Which type of supplement drug interaction does this represent? Is this a pharmacokinetic interaction, a pharmacodynamic interaction, or is it not an example of a supplement drug interaction at all? And the answer is A. This is an example of a pharmacokinetic interaction. This alters the movement of drug through the body. It changes the absorption of, if calcium and a drug are binding together, less of the drug will be absorbed from the gut. So another interaction that I like to talk about, and it's very important here in Hawaii because our pharmacy program is located just next to an area of the Big Island called Puna. And out in Puna are large orchards and manufacturers of noni and noni juice and noni products. So this is a big concern here among our patients, but it's a growing problem all over the world because noni juice is becoming more and more popular as a dietary supplement. And the concern is that noni juice contains a very high concentration of potassium. And for a normal person, this might be a really great thing. This is a great way to get potassium. There's far more potassium in noni than in any other product we know about, including bananas, which are usually touted as being high in potassium. But the problem is that noni juice can increase the amount of potassium or the blood level of potassium in the body, and that this can lead to a condition called hyperkalemia, or very high potassium, abnormally high potassium, and this can actually be life-threatening. Now again, as I mentioned, for a normal person this is not an issue, but there are prescription drugs that actually reduce the amount of potassium that is excreted from the body. Some of these drugs, examples include what we call ACE inhibitors. An example might be lisinopril. These are drugs that are often used to treat high blood pressure, to treat heart conditions. There are also drugs that are called ARBs. An example is losartan. These are also drugs that are used to treat high blood pressure and to treat certain heart conditions. They're very commonly used. And then a third example is the drug spironolactone, which is also used to lower blood pressure. It's used to remove excess fluid from the body. All of these drugs, as a consequence of their actions in the body, reduce the amount of potassium that is eliminated in the urine. And if taken at a time when noni juice is also consumed, the noni juice is going to increase the amount of potassium in the blood, and the ACE inhibitors, the ARBs, and spironolactone are going to prevent excess potassium from being excreted, increasing the risk of hyperkalemia or abnormally high potassium. This is a major potential drug interaction. The severity of this will be high if it occurs, and it's very possible. So we want people to avoid noni juice if they're taking ACE inhibitors, ARBs, or spironolactone. Now, that's the end of the examples of interactions that I wanted to highlight. There are many, many more, but this gives you a variety of examples of interactions, both pharmacokinetic and pharmacodynamic. I did want to touch on one other piece of information. I found this many years ago and found it quite interesting. How many of you have heard, I know I can't hear you, but just think about how many of you have heard that a long historic use of an herb is evidence for its safety. And that's a very common sentiment that's expressed, especially within the world of complementary and alternative medicine. And I encountered this statistical evaluation some years ago that demonstrates that this may not be an actual reliable conclusion, that long history of use is evidence of safety. In fact, it may not be. And what this table tells us is that if a product has a frequency of a side effect or an adverse effect in 1 out of 100 times that it's used, it has a 1% chance of having a side effect in a person. It will take seeing 300 people and using this drug in 300 people to see one case of the side effect. It will require giving this drug to 480 people to see 2 examples of the side effect, and you have to give the drug to 650 people to see 3 cases of the side effect. So when a 1% side effect frequency is not huge and it's not inconsequential. But if we talk about side effects that don't occur very often, let's say 1 in 10,000, it would take giving the drug to 30,000 people to see one example of the side effect. You'd have to give it to 65,000 people to see 3 examples of the side effect. And the reason these numbers are relevant is it's predicted that a practitioner will typically see somewhere between 25 and 30,000 patients in their practice lifetime. So if a product, whether it's a drug, an herb, a supplement, has a fairly low frequency of a specific side effect, it's very unlikely that a practitioner would see 3 examples of this in their practice lifetime. And it's been estimated that it would take seeing an occurrence 3 times for a practitioner to associate the side effect with the drug, the supplement, whatever the product might be. So I just wanted to offer this up as another way to look at the whole issue of side effects and the value that a database that has this kind of information, not just the interaction information, but side effect information, can have in helping people in practice to be aware of potential side effects they may not have heard of, they may not have seen, but may have been cataloged somewhere and registered in that reference or database. So I wanted to lastly offer you a variety of different resources that you can turn to for natural medicines related information. The first 3 are quite good, but they do not offer a comprehensive drug supplement or supplement drug interaction checker. ConsumerLab.com is a subscription resource that tests and reports on dietary supplement products in the US, and part of their website is the Natural and Alternative Treatments Encyclopedia. It's very well put together. It's written in very easy to understand language, but again, it contains no interaction checker. Health Notes or IL-7's products are quite good. They're seen in many kiosks in stores, and they're licensed quite often for supplement manufacturer and sale websites. But again, at this time, the Health Notes products do not contain an interaction checker. And then the third one is Medline Plus Herbs and Supplements. It's a very good source of consumer-level information about dietary supplements, herb and non-herb supplements, but it does not contain an interaction checker. The next 4 that I want to talk about do contain interaction checkers. Hopefully you're all familiar with the Natural Medicines Comprehensive Database, and it contains the most comprehensive interaction checker available. And I just wanted to point out that the information from the Natural Medicines Database is, in its consumer form, the basis for the information in the Medline Plus Herbs and Supplements database. Natural Standard is a second reputed natural medicines information resource, and they also have a drug interaction checker, supplement drug interaction checker. There are 2 drug information resources that some of you may use if you're health professionals, or you may have access to if you're working with health professionals that are licensed. In hospitals and clinics, you'll often see these products available. Facts and Comparisons does contain a module, the review of natural products. It is not as valuable a tool for clinicians as the Natural Medicines Comprehensive Database, as Natural Standard, but it does have some information. And there is quite a good drug supplement interaction checker in Facts and Comparisons, as there is in LexiComp, which is another drug database that has a natural products database module associated with it. So with that, I'm going to turn it over for questions. I'd like to thank you for your attention. And let me see if I can get back to the window here. I think it's this one. And let's see, there we go. Kelly, perhaps you can help me here.
Hi, thank you, Forrest. I am going to change the presenter back over to May.
Great.
And what I can do, I see we've got a couple of questions that
I'm sorry, Tracy.
Yes, I have a couple of questions that we have from the presentation, and I can highlight those for us so you could maybe talk a bit to them.
Sure.
The first question was from Sarah, and it goes back to the information about grapefruit. And Sarah would like to know if the grapefruit interaction also applies to SSRI antidepressants.
I don't remember off the top of my head, but it's an easy interaction to look up, especially if you have the natural medicines database accessible. I also do want to mention, especially regarding grapefruit juice, that there is a Canadian pharmacist who has put together a terrific website, and he keeps up specifically on citrus and drug interactions. There are other citrus fruits that also interact with drugs, and many that do not. It depends on whether or not they contain a specific ferrarocoumarin constituent. And it's a publicly available free website. The pharmacist's name is Dean Elbe, E-L-B-E, and if you Google grapefruit drug interactions, you'll find the website. It's got an odd name that's not easily memorable, but it's very easy to find. You can read all about grapefruit juice drug interactions. You can read about the variety of drugs that have been documented, those that are suspected to interact, as well as, again, the potential for interactions with other specific types of citrus, and he really helps understand clearly which citruses are potentially problematic and which are not.
Okay, great. And I'll also find that link for everyone, and I'll send it out with the recording of the presentation, so you'll have that as a resource. As a follow-up, Sarah's also asking if you have any recommendations for specific texts that would be helpful for further study of the herb-drug interactions. I know, for instance, here in the college store we have the PDR for herbal medicines and some other resources. Do you have any favorites?
As a practicing pharmacist, I actually encourage people to stay away from texts.
Okay.
The reason is that the publishing process is so long that by the time a text is published, it's usually at a minimum 1 year and as much as 2 to 3 years out of print, out of date. And so that's why I encourage everybody who works with herbs and supplements to have access to a well put together online database that is kept up to date, and what you see when you look today is the most up-to-date information that's available. Right. I will tell you that from a reference quality standpoint, the herbal PDR is a fairly poor reference to be using. The PDR series of references are published by a company called Medical Economics. And what they do is they include information that has been paid for by manufacturers who want the names of their products or the information about their products listed. There are far better resources that you can be using, including the Natural Medicines database, Natural Standard, the database that's in ConsumerLab.com. ConsumerLab.com, I think, costs about $30 a year for a subscription, and you get the access to the database for the year. So it's a pretty good deal if all you want is the database. But that's my perspective as a pharmacist, where pharmacists really need to know the most up-to-date information, not information that was accurate, but as of a year or 2 or 5 ago.
Great. Well, for everybody on the call who is a current student, you do have access to both the Natural Medicines Comprehensive Database and the Natural Standard Database right through the virtual library in your classroom. For those of you with us that are graduates, there is discounted subscriptions available to our graduates, and let me know if you're interested in that, and I can send you more information, because both of them really are invaluable as practitioners, and Dr. Batz has provided us with some additional resources. I know we have another question from Kelly that's a little bit different, but first I want to bring up Audrey's question about whether there are supplement and drug interactions that are intentionally used for a benefit.
Yes, and the example that I gave of niacin and the statin drugs, the cholesterol-lowering drugs, is one example. That the statin-lowering drugs will lower cholesterol. We know that niacin is very effective at lowering cholesterol. The combination of the two is more effective than either of them individually. So by two biochemical mechanisms in the body, two different ones, cholesterol can be lowered substantially better with the combination than with either alone. But especially because the statins are prescription drugs, it's important that whoever is prescribing the statin is aware that the patient with whom they're working wants to use niacin, and that this isn't something that the patient just starts to take on their own or with the advice of somebody who's not a prescriber in the absence of the prescriber's knowledge.
Okay, thank you. And it looks like the last question is from Kelly, and it goes back to calcium. Do the drugs also reduce the efficacy of calcium as a supplement?
Well, yes, from the standpoint that if calcium and a drug bind together, less calcium will be absorbed as well as less drug. We already know that calcium has relatively low absorption, and so we want to maximize the absorption of calcium whenever a person is taking it, because we know that adequate calcium intake is necessary to maintain strong bones. So yes, the answer is that the effect goes both ways. And so separating the ingestion of calcium and the ingestion of the drug by several hours can both increase the absorption of calcium and of the drug and of the benefits of both.
Okay, thank you. Well, go ahead.
I just wanted to mention I have a separate computer running in my office, and I just looked up in the Natural Medicines database. I don't see an interaction between SSRI antidepressants and grapefruit juice listed. So that is not a potential concern at this time.
Great. Well, thanks for doing that. And this has been a wonderful webinar. It's something that we have a lot of students asking us for. I want to assure all of you that the transcript, the recording of today's webinar will be made available to everyone, whether you're a current student or a graduate. So we'll make sure that you get that. And Dr. Batz will also be doing another webinar later this year, on, hopefully in the fall, on using the Natural Medicines Comprehensive Database specifically. So definitely keep an eye out on your email for that invite, and I think that would be a great webinar to participate in. Do you have anything else for us, Dr. Batz?
Yeah, I just wanted to, first of all, thank you for the opportunity to make the presentation, and also to offer that if there are any questions that occur after the webinar today, that I welcome people to email me here at the University of Hawaii. I'm happy to answer questions, provide them with resource information, whatever can help them to better utilize or better guide in the use of dietary supplements of herb and non-herb products.
Wonderful. Thank you so much. It's been an honor to have you, and we'll look forward to having you again in the next few months.
Thank you, Tracy.
Thank you. Thank you, everyone, for joining us. Have a wonderful afternoon.
Aloha.
Take care.